Chapter 13. The next chapter in stroke recovery. While we have learned a great deal about stroke and the brain in the past several decades, there is still so much we don't know. Researchers around the world are making huge discoveries and exploring exciting new treatments for brain repair. Some of these advances are already in use in research clinics, while others are still undergoing safety or funding approval for widespread use. More are still in development but hold huge promise for helping stroke survivors 5 to 10 years down the road. Our experts are on the cutting edge of stroke recovery and share with us their vision of the future. Dr. Dylan Edwards of Burke Rehabilitation Hospital, a physical therapist and leading researcher in robotics, joins our other experts to share his knowledge about the promise of future stroke treatments. Question 96. What is the future of stroke recovery? Dr. Chu, there have been huge advances in the last couple of decades in both stroke prevention and acute stroke treatment. These have been so successful that we've seen a dramatic drop in stroke mortality rates. In the first few hours after a stroke, we have a window of opportunity to use interventions like TPA, the clot-busting drug, and mechanical clot retrieval. These are things that can make a difference, but they have to be implemented almost immediately. The big gap in the field right now is in the area of stroke recovery. A lot of people will say, my doctor always talks to me about things I can do to prevent a stroke, but what do I do about the stroke that I had a month ago, a year ago, 5 years ago? And quite honestly, for many years, it looked pretty grim. I'm now seeing tremendous promise with the types of stroke recovery therapies we might be talking about in the future, in just a few years. I've been a stroke neurology specialist for 20 years, and this is the first time that I really feel tremendous optimism that we might be on the doorstep of something big in stroke recovery. Dr. Roth, at the end of the day, what's most important is to recognize that it's likely going to be a cocktail of all these great advances. It's going to be a combination of brain stimulation with cell therapy, along with exercise and robotic devices. We don't yet know how much of each or the timing, but that's going to be what's most important in the rehabilitation process in the future of stroke recovery. Question 97. What is robotic therapy? Dr. Roth, when we think about technology, we make a distinction between assistive technology and therapeutic technology. Assistive technology allows the individual to interface better with his or her environment. For example, a wheelchair is assistive technology because it allows the person to be mobile in the community. Certain electronic devices that open curtains or answer the phone when you speak or push a button are assistive technology. These are compensations. Therapeutic technology is where a person operates robotic arms or legs, so the robotic device is actually helping to strengthen the primary function. It's actually making the person stronger or helping the person walk with better balance. These are important approaches, and while they're not fully implemented in rehab yet, we're seeing them used more. Dr. Edwards, robot-assisted therapy is not science fiction. You can think of robot-assisted therapy as a piece of equipment you might find in a gym or health club. It's a powered device that attaches to a patient, has advanced controllers, and interacts in real time with the capabilities of the person it's exercising. It has an exquisite ability to sense what the person is doing, and according to pre-programmed rules, it offers assistance as needed. As the person improves over the course of therapy, the robotic device backs off the amount of assistance it's providing, leading to better function. Robotic-assisted devices are a contemporary technological method of providing the repetitive assistance that a therapist would normally provide without the physical strain on the therapist. We know that the patients need to perform many repetitions, and these robotic devices can do it tirelessly. It's a great way to embrace emerging technology to the benefit of patients. The duration of therapy with a patient is likely a critical element in achieving good results. We typically provide 18 to 36 sessions over 6 to 12 weeks, 3 times a week. We know that for a single session in the upper extremities, 1,000 repetitions will last around an hour. That means we can get in up to 36,000 repetitions. Just like practicing a tennis serve or a swimming stroke, you need to do many repetitions. You can't simply do a few repetitions or a couple of sessions for the adaptive plasticity in the brain to actually take hold. It has to be done over a long time for durable effects. What kind of results can people expect from robot therapy? If we take people a year after their stroke, people who have regained some function but still have some residual hemiparesis, and we engage them with the robots we use in our clinic for 36 sessions, then we expect to see change well over and above what people think is clinically meaningful on average. That said, some patients don't respond so well, and others respond well beyond that. We're trying to understand which people are responding and which are not responding and why. We're also trying to do more robust therapy by adding other treatments on top of the robot therapy, such as brain stimulation or plasticity-enhancing medication. Using this paradigm, we do see clinical meaningful effects across a whole group of subjects. A lot of hospitals haven't embraced this technology yet, mainly because of a combination of the expense, the practicalities of training the staff's personal preference for therapies, and perhaps the efficacy data. There are a number of larger academic hospitals that have started to use this technology and see the benefits for the patients and the cost savings. As for insurance covering this type of treatment, it's not a therapy that is billed separately, but just another tool a therapist can use during a normal therapy session. Not all robots are the same, just as not all medications are the same. They're really quite different and come in all shapes and sizes. Some are exoskeletons that look like an Iron Man suit, while others are small and bolted onto another device. In stroke recovery, we want to get people using as much of their residual biology as possible to get their muscular systems back online, instead of using full robotic suits that do things for them. There are both cardiovascular health benefits and psychological benefits to improving your own body. There are certain things that distinguish robotic therapy devices from other kinds of exercise equipment. A robotic therapy device must have a mode that can provide assistance, and it must interact with the patient, adapting the assistance according to the abilities of the patient. If it doesn't do those two things, it isn't truly a robotic therapy device. They're a relatively new technology, so we're still trying to understand what the key components are and what will work best. Something that's proven with one particular robot may not transfer to another robot. Something that's proven in the upper limb may not transfer to gait training because the motion of controlling the hand is different from walking. We need to look carefully at what the robotic devices are and what they do, and which ones have actually been tested on which patients. In general, the upper extremities, the arm and hand function, have been studied much better, so there's more evidence supporting robotics there. The lower extremities and gait training are arguably equally or more important, but there's a bit less data to support the use of robotics there. Both are very promising. How much benefit we can expect, which robots are best, and which are best for which patients really depends on a couple of things. One is the patient's pathology and stage of recovery. The second is the goals of the patient. People have a finite amount of time, and they're trying to live their lives. They can't spend 100% of their time doing therapy. Some might be more interested in improving hand and arm function than improving gait training, and vice versa. It depends on what the person's goals are. As for the patient, a good candidate would be somebody who's not completely paralyzed, somebody with a small amount of voluntary movement. Question 98. What do you mean by brain stimulation? Dr. Roth. There's a lot of interest and a lot of activity right now in something called neuromodulation, which basically is stimulation of the brain. There's transcranial magnetic stimulation, or TMS, applying a magnetic field to the brain, and also electrical stimulation, applying electric current directly to the area around the brain injury or to the other side of the brain. Both are non-invasive, stimulating the outside of the skull or scalp. What's been really interesting is seeing that combining the stimulation with exercise may actually result in improvement in brain function. It's not used clinically yet for day-to-day practice, but there are lots of studies and many centers that are experimenting with this, and I expect at some point soon it will be used everywhere. Dr. Page. We use brain stimulation at our lab. The idea of applying an electrical current to the brain has been around for quite a while. With TMS, what we're essentially doing is applying a magnetized electric coil to the scalp of the patient. Underneath the scalp is the brain that has had a stroke. Depending on where we apply the current, we can affect the part of the brain that controls walking, hand motion, or speech production. Depending on where we place the coil, we can either facilitate or inhibit those areas of the brain, making more or less activity happen in those regions. Now the questions become, how much current should we use? How should we structure the practice that goes with that brain stimulation? And which side of the brain should we target? The side that has had the lesion versus the side that doesn't, or both sides at the same time? What we do know is that it has an effect. There's very good evidence suggesting that it seems to speed the process of recovery after a stroke, and we're pretty sure what the mechanisms are. Unfortunately, it's not something that is widely used in rehabilitation at this point because it's not FDA approved for stroke right now. At the moment, brain stimulation is approved only for depression. We know it's safe. The only side effect is seizures. They're rare, but they do happen. We're very concerned with safety in applying something to the brain, so we used established screening criteria before using it. Another type of brain stimulation is transcranial direct current stimulation, or TDCS. TDCS is safer than TMS because we're applying a less focal and less powerful current to the brain. The procedures are basically the same. We're using electrodes and a low-level stimulator instead of a big coil. The amount of stimulation is much lower in TDCS, so it's even safer. A status report on brain stimulation. Transcranial magnetic stimulation, or TMS, is one form of brain stimulation. There are several different types: single pulse TMS, repetitive TMS, or RTMS, deep TMS, or DTMS, and navigated TMS, or NTMS. TMS is currently FDA approved for the treatment of depression, but clinical trials suggest that TMS may also act as an effective part of stroke recovery treatment by stimulating growth in brain cells. These stimulation devices are currently used to help stroke survivors make faster gains in their recoveries at university hospitals conducting research. Combining TMS with other standard therapies may help patients regain speech and movement. NextStim is a company focusing their research on TMS and stroke recovery. Their ContraStim stroke study found that people who received TMS combined with occupational therapy made more gains than people receiving occupational therapy alone. After these promising results, NextStim conducted a trial at 12 of the top rehabilitation sites in the United States. A Phase 3 trial found no safety concerns in the patients enrolled in the trial. While TMS is currently considered off-label for stroke recovery, doctors who already use it in their practices to treat depression may be willing to use these devices to help stroke survivors. Before deciding to undergo TMS, however, patients should talk to their doctors to learn the risks and benefits of this treatment. While legal, off-label uses are not covered by health insurance. If you're paying out of pocket, a course of TMS is expensive, costing several $1,000s. Health insurance does sometimes cover TMS if it is being used to treat depression that has not responded to antidepressants. So this is an affordable option for stroke survivors who are also experiencing depression. Since up to 1/3 of stroke survivors experience depression, this can be a worthwhile, drug-free alternative to prescription antidepressants. As of 2016, there are 4 TMS devices that are FDA approved for depression: Neuronetics NeuroStar TMS therapy system, MagVenture's MagVita TMS therapy, MagStim's Rapid Therapy system, and BrainsWay's Deep TMS. To find a provider near you, check their websites: www.neurostar.com, www.magventure.com, www.magstim.com, and www.brainsway.com. NextStim's Navigated Brain Therapy, or NBT system, treats stroke and is based on TMS technology. Initial studies of this TMS combined with therapy show a 2-fold improvement when compared to therapy alone. NextStim is preparing to seek FDA clearance for using the NBT system in stroke rehabilitation. You can follow updates on the status of the NextStim NBT system on their website at www.nextstim.com. Transcranial direct current stimulation, or TDCS, is another form of brain stimulation being researched. Like TMS, TDCS is not currently FDA approved for the treatment of stroke rehabilitation. However, there are doctors who may be willing to use the device off-label to treat stroke survivors. But remember, since it's not FDA approved, it won't be covered by insurance. Again, TDCS would have to be combined with physical, occupational, and speech therapy to maximize effectiveness. Stay away from TDCS devices being sold on the internet for home use. They could potentially be dangerous for a stroke survivor, as a TDCS device must be specialized to meet the unique needs of a stroke survivor. Dr. Roth, there's intriguing research on what's called brain-computer interface. This is when you implant electrodes in the brain, and then the electrodes sense what the brain's thinking and convert that into the movements of a computer or prosthetic device. The electrodes are there to sense the electricity of the brain instead of stimulate it. The brain-computer interface is still very experimental, mostly because it requires neurosurgery to implant the electrodes. Now, there's some research looking at placing electrodes on the surface of the scalp instead, using what looks like a bathing cap with electrodes all over it. The person will wear those electrodes to let the computer read the brain waves and be able to act. Keep in mind that the brain waves are not read very clearly because you've got the whole scalp to go through. It's a very interesting approach, but we're still a ways away from using it. Question 99. What's the scoop with stem cell therapy? Dr. Chu, a very exciting area of research is in stem cell therapy, or cellular therapy. These treatments are now in randomized controlled clinical trials, and so far the results are promising. The stem cell therapies we're investigating now may modify the inflammatory reaction that occurs in an acute stroke, as well as enhance neurogenesis and angiogenesis, or the development of new brain cells and also blood vessels, through a growth factor effect. Dr. Carmichael, stem cell therapies really look hopeful for the stroke recovery field. It's a pregnant moment because the science of neurorepair in the brain is reaching a maturation point. We have strong candidates for drugs that might promote recovery. It's going to take 5 to 10 years, but at least we're there in the laboratory stage. The ability to enhance neuroplasticity with a cellular therapeutic is being seen in the preclinical studies of the rodent models of stroke, promoting dramatic recovery. Now we're in the phase of understanding why that occurs and how we might translate it into humans. We understand stem cell biology more, and we're starting to understand how to work with stem cells to make them applicable to human brain diseases. In some cases, we're now in phase 2 clinical trials that might provide a therapeutic option. It's a pretty dramatic scientific time. When people say stem cells, they mean a lot of different things. The best clinical trials to date that have shown recovery have been early phase 1 trials. They were looking to see if stem cell therapy was safe, but there were some really surprising examples of people with chronic stroke who got dramatically better. Now these treatments are moving into phase 2. These treatments involved direct cell injections into the brain through a very small hole in the skull. Stem cells are a big field. There are a lot of therapies being tested, and we're still a ways from a clinically validated approach, but it's very promising. The most important thing to realize is that we are still about 5 to 7 years away from a clinically tested and validated stem cell therapy. In Southern California, a lot of patients will go to Mexico to get cell injections and therapies that are not clinically validated. It's not always known what is being done to the patient. In some cases, it causes harm, and it always costs a lot. These offshore therapeutics are a concerning element in the field. We must be patient. There's a real risk of patients falling prey to people who are not physicians, but really business entrepreneurs who are promoting these approaches.
We all want to be better instantly. There is no simple cure for stroke, so we have to adapt for now. I use a lot of assistive technology to help me adapt to my language problems and being one-handed. It took me a long time to accept that I'm not going to recover 100%, but I can still live the life I want. I already exceeded all expectations in my hard-fought recovery journey, and new treatments like stem cells make me hopeful that I'll be taking my recovery to the next level someday soon. David.
A tip. One of the most toxic feelings to human beings is hopelessness. So I'm incredibly excited there's so much progress in the world of stroke recovery to help us all feel hopeful. When I stumbled across the result of the first major study of stem cell therapy for stroke survivors, I thought, wow, how can I get this for David? My family and I already have hope because we see the man David has become and the progress he's made. Now it appears there is new, game-changing research that gives us even more hope. So today, use all the therapies and treatments that are readily available, along with the simple lifestyle changes in diet and exercise that we know work. Tomorrow, you can look forward to the dawn of a new era of treatment. In all likelihood, combination therapy, which combines the tried and true therapies we have now with cutting-edge treatments like stem cell therapy, will be the answer so many stroke survivors are now seeking. The promise of stem cell therapy. Clinical trials using stem cells in stroke survivors started in 2005, and the results of the trials have exceeded expectations. There are 4 questions researchers are seeking to answer through these trials. Number 1, is it safe? Number 2, does it work? Number 3, is it more effective than existing therapies? And number 4, what are the long-term results and side effects, if any? With the promising results of recent studies, it appears stem cell therapy could be a widely available and incredibly effective treatment for stroke survivors in the next 5 to 10 years. Research using stem cells in stroke rehabilitation is progressing rapidly, so consult reputable sources and your doctors to stay informed about the latest updates. Here's a glimpse of what recent stem cell studies have found. In one study, stem cells were safely infused into the brain through the carotid artery when given 2 weeks after a stroke. There were no harmful effects in any patients in the trial after a year of stem cell injections. Co-principal investigator of the study, Dr. Dilip Yavagal, said, "The conclusions of our research prove that stem cells are safe when given through the carotid artery with a small catheter." Dr. Ralph Sacco, Chief of Neurology Service at Jackson Memorial Hospital, which was one of the sites of the study, said, "This study opens the door to future clinical trials that will explore new methods of repairing damage to the brain with cell-based therapies." Stroke researchers now know that stem cells can be used safely and efficiently without compromising the health of the patient. We have more work to do in this promising area to improve the outcomes of our stroke patients. Following the success of that study, stem cells were safely infused directly into the brains of stroke survivors by using a procedure that required just 1 night in the hospital. The patients in this study had a stroke between 6 months and 3 years prior to treatment. Dr. Gary Steinberg, who led the trial, said, "It was designed primarily to test the procedure's safety, but patients improved by several standard measures. Their ability to move has recovered visibly. That's unprecedented. Some patients couldn't walk. Others couldn't move their arm. This wasn't just they couldn't move their thumb and now they can. Patients who were in wheelchairs are walking now. We know these cells don't survive for more than a month or so in the brain, yet we see that patients' recovery is sustained for greater than 1 year and in some cases now more than 2 years. Older people tend not to respond to treatment as well, but here we see 70-year-olds recovering substantially. We thought those brain circuits were dead, and we've learned that they're not. As of June 2016, these researchers are seeking to enroll subjects in a multi-center Phase 2b trial. Stem cell therapy research in stroke survivors is now taking place around the world. In November 2015, the first stem cell injection in a 66-year-old stroke survivor in England was used to help the woman regain use of her arm. Soon, stem cell therapy may be available to stroke survivors in the United States and abroad. Takeaway points. The future of stroke recovery is very bright. In the next few years and decades, we will be seeing many new treatments that have powerful results when combined. Be on the lookout for these advances. Better assistive technology to help you do the things you can't. robotic therapy that provides assistance as it adapts to your abilities, electromagnetic stimulation that activates or inhibits certain parts of the brain, stem cell therapeutics that help the brain create new connections or heal faster. All these advances must undergo extensive research and testing for safety and efficacy. Be careful of people selling unapproved treatments. Until new treatments are approved to work for stroke, focus on the therapy and principles that are proven to work.